Thank you very much, Ramesh sir, for your wonderful introduction. Always a pleasure to be among the select panel of speakers. Thank you, sir, and thanks, Arul sir, for this amazing opportunity. Well, I'm going to talk on phaco in colobomatosis. And here we are planning to stick to only congenital colobomas. The common ones that we usually see are the inferonasal iris colobomas. These are the ones which we usually see. Colobomas in other locations are very rare, and sometimes they can be associated with lens colobomas. These lens colobomas are not actually true colobomas. They happen due to zonular and ciliary body defect. And sometimes we will be able to see that there is a small notch in the lens, and usually it will be associated with absence of zonules in the colobomatous areas. So I have 6 pointers for phaco in colobomatous eyes. To begin with, the first point that I would like to emphasize is a proper preoperative assessment is very, very important in colobomatous patients. The reason being, the zonular integrity assessment is very important, which will help us to plan what sort of a support system we are planning to use for the case. And we have to counsel and ensure that the patient gets the cataract surgery done at the earliest. The reason being, already the capsule support system is less. And in case you have a hard cataract and you want to do a chop or a divide and conquer or a stop and chop, the amount of manipulation we will have to do inside the eye will be more. In case it is a soft cataract, things get much easy. The lens is less bulkier and it is far more easier to do. So counseling the patient for early intervention is very, very important in phaco in colobomatous eyes. So regarding the capsular support system, usually if there is about a 3 to 4 clock hour of capsular deficiency, we will be able to get reasonably good results with the capsular tension ring, which can be supported with the haptic of the IOL. If the defect is more than clock hours, it is better to use a capsular tension ring, a Sionis ring, or a CTS along with the CTR, which will give additional support. With this can be managed up to 6 clock hours, and if it is more than 6 clock hours, it is always better to have your PR surgeon backup and to do a scleral fixated lens. So choosing the support system is of prime importance. What sort of a ring you will want to use? This is an image of a simple capsular tension ring. This is a Sionis ring. It comes in 3 designs. Based on where the coloboma is, we can decide where the ring segment can be and where the support, maximum support is needed. So planning is very, very important for coloboma. This is a CTS, this is a segment support, which can again be used in addition to a CTR. Little bit of suturing is needed in these cases. Well, this was a patient which we operated. Patient has a inferonasal coloboma, and you can see here some amount of zonular support also is missing. This is about 3 clock hour of zonular support missing. Luckily, we were able to counsel the patient and get him to theater at a little early stage. This is not a hard cataract. The second point that I would like to tell is beginning the rhexis is very important. Rhexis in these cases with little bit of zonular deficiency or zonular support being absent is very difficult. So we should begin the rhexis where the support system is maximum, preferably more than about 180 degrees away from the area of zonular defect. In this case, we had an inferonasal defect. So it is always better to start the rhexis, bang opposite to it. And you can see here, this is the area where the defect is. So we started the rhexis here. You can see here, this is where we started and we were able to complete it easily. Instead, if you start here at the area of zonular defect, getting the tag is very difficult. Once you get it, you will be able to manage. But at this point, if we get stuck and the rhexis run away, then we are lost and getting the rhexis will be very difficult. So that is something that is very important. Once you get the rhexis, the third point I would like to tell is doing a hydro, we should be very, very, very cautious. We need to do gentle mini hydro dissection in multiple points and not look to get one full wave from end to end. And the site of doing the IA also is important. As you see here, the defect is here. We are trying to do a hydro here so that the wave can come up to here. You try to do a hydro in this quadrant, the wave will come here and cause more trauma to the zonules. So you should ensure that the wave also comes in some other quadrant other than the area of zonular defect. Mini hydro is always better. Do it slowly. In multiple quadrants can be done. This being a soft cataract, we did a hydro dissection, a gentle hydro dissection, as well as a delineation. This step is something which is very, very crucial. Before you start your phaco, it is better to do everything slowly. Maximum, we will be spending about 2 to 3 minutes more inside the eye, which is really worth it and will give brilliant results post-operatively. So start phaco slowly. Before you start your case, it is ideal to slightly lower your bottle height so that the iris turbulence is less, lower your aspiration flow rate and your vacuum. Say, for example, you usually have a flow rate of about 40. I usually prefer to go down by about 20%, which will slow down your surgery about 20%, and you will be able to have more control. In other ways, even if something happens, we will be able to get away with it. Do a phaco slowly. This being a soft cataract, I didn't attempt a chop. Doing a stop and chop, slowly, gently do your phaco with slow parameters. You can see here the iris is trying to push itself and come out. After phaco is over, taking the probe out, again, we should be very cautious. This should be treated like a case with a posterior capsular rupture or a case with zonular dehiscence. If you pull the phaco probe out, there is a high chance that the anterior hyaloid face may be disrupted and vitreous may come through the colobomatous area. So inject viscoelastic and then pull the probe out. And beginning the IA also is very important. Like your rhexis, it is ideal to begin your IA at the area where we have maximum zonular support and do the IA at the point where there is zonular loss at that area last, so that you'll be able to visualize better and do the case much more comfortably. So injecting viscoelastic and pulling the probe out is of prime importance. IA, again, do with low parameters, not your usual parameters, at least 20% lesser. Hold the cortex, pull it to the center, and then aspirate. Do it slowly and gently. It is always okay to spend those extra few minutes rather than trying to be in a hurry. And then placement of CTR. There are several articles and talks on when and how to place the CTR. I personally feel comfortable placing the CTR as late as possible and as early as needed for that particular case. The reason being, visualization is quite difficult with a bulky nucleus in place. So I prefer to place a CTR after I finish my rhexis and my phaco. Because once you have, if you have the nucleus in place, getting the CTR into the bag itself is difficult. After we finish the IA, after we finish the hydro, it gets even more messy and visualizing is difficult. And I have personally have situations where I put the CTR in the sulcus and getting the CTR out is very, very difficult. In fact, close to impossible. You will have to put another ring and there is a chance even the CTR may drop through the area of zonular weakness. So I prefer to place the CTR late. In this case also, with great precautions, we managed to do the IA, phaco, as well as the hydrodissection comfortably, and we placed the CTR quite late. This is what we learned from HAMEED study also. Main advantage is visualization is much better and you're absolutely sure that you get the CTR into the bag. However, if you're not able to do your rhexis and the zonules are very loose, it can be placed earlier also, but you have to be very cautious and ensure that it goes exactly into the bag. And placing the haptic also can be done comfortably. This case, you can see here that we are placing the CTR into the bag. It can be either injected or pushed into the eye. I'm more comfortable threading it into the eye and using a dialer. This has to be done slowly and not very fast because again, the CTR may go into the sulcus. So gently go into the bag and slowly drop the CTR into the eye. And placing the haptic can be positioned in such a way that that also adds on to the support of the capsular tension ring and gives more support. I'd like to thank AOS, Partha sir, and my mentor, Arulmozhi Varman sir, for this wonderful opportunity to talk on phaco in colobomatous eyes. Thank you very much for your patient listening.